Hi, everyone. Welcome back to UCLA Health's Medically Speaking. I'm Dr. Eve Glazier. Today, we're talking about neurodiversity, and specifically autism, what it is, what early signs can look like, and what the science actually says, and especially what supports can make a real difference for kids and families. Let me be clear, this is a conversation for everyone. Neurodivergence shows up in every classroom, every family, every workplace, and every community, as students, friends, partners, colleagues, and loved ones. Autism alone is identified in about 1 in 31 children. And it's important to say this up front. Neurodiversity is the idea that there isn't one single right way for the brain to think, learn, communicate, or experience the world. Differences aren't deficits. The real question is, what helps a child thrive and what barriers can we remove? My guest today is Dr. Shafali Jeste, professor and chair of pediatrics at UCLA Health, a child neurologist, and a national leader in early brain development and autism research. Shafali, I'm so grateful you're here. Thank you.
Thank you for having me.
Shafali, before we even just dive into this, I would love to know what drew you to pediatrics in the first place, and then specifically child neurology.
Yes, that's a great question. So I've always loved kids and was always really fascinated with child development and trying to understand, why do kids develop a certain way, not just in terms of like atypical development, but even in terms of how do kids develop their personalities and their interests. And so, interestingly, when I was in college, I was a learner. I loved to sort of ask questions and figure out ways to answer them. And so I studied philosophy as a philosophy major. And that training was really valuable for me because it kind of taught me how to think creatively about questions and how to actually honor different perspectives. But I also knew I was always going to be a doctor and try to kind of answer some of these questions from a medical standpoint. And so when I went to medical school, I was deciding between child neurology, developmental behavioral pediatrics, child psychiatry. And I had a mentor at the time who said, you have to decide on a specialty based on loving the bread and butter. So I spent some time, in rotations in all of those three areas. And I loved the bread and butter of neurology, which is, developmental disabilities and challenges. It's epilepsy or seizure disorders. And I also love that we, in neurology, study the brain, which is like the big puzzle, but also kind of the answer to a lot of these questions. And so that's how I chose child neurology. And interesting, while I was in training was when we were starting to diagnose all these kids with autism, and all these parents would come to us and ask, okay, you've diagnosed me, now what? Why does my child have autism? What are the next steps? And so I felt like pursuing a career in child neurology would help me hopefully answer some of those questions.
I mean, I love that. I love the intense investigation of questions.
Yes.
I love that thread, though, from philosophy to neurology.
I wish I had time to read those books still, but they're all in my bookshelf.
I'll be in that
so it
book
makes
club
me look
with you.
Really smart.
Yes.
But I haven't read any of them for
You're like join my
30
Kant
years.
Nietzsche book club.
Exactly.
I'll join. Sign me up. No, but that's really interesting, actually. I mean, and I think that thread is actually incredibly interesting. So you actually mentioned kind of really then what is child neurology, and you mentioned kind of the brain, nervous system, and development in children. When we say neurodevelopment, what does that really mean?
Yeah, it's a great question. It gets used a lot. And really, I think the word sort of explains itself, which is neurodevelopment is literally the developing of the brain, right? And so when we think about neurodevelopment in kids, what we're characterizing is how is the child developing? And we know that a lot of those aspects of development, whether it's the way they learn to develop, language, the way they even perceive the world, those are all rooted in the brain, in neuro. And interestingly, we know that neurodevelopment is largely kind of rooted in the way the brain is wired. And those connections, amazingly, we start with the amount of neurons we're basically going to have, unfortunately for us, at birth. Those are the ones that we end up with. But the connections change and develop over time, and they're very much influenced by experiences and inputs. So that process is continuing to change, which is why we think of it as development.
It's so interesting, though. So I guess then I really would love to hear from you how you would define autism, really for a general audience.
Yeah. Also a great question because it's an ever-evolving definition.
I'm sure that it is.
But the one other thing I would say about autism is that it, again, as I said, it's sort of at its core a diagnosis based on challenges and social skills. What's created a lot of, I think, confusion and just challenges in the space is that the old DSM, which now is over 10 years ago, had a lot of like specific diagnoses under this umbrella of what they called PDD, or pervasive developmental disorders. So there was Asperger's, autistic disorder, PDD, NOS, not otherwise specified, which is like kind of a bit of a wastebasket term for anything that doesn't fit the other two. The new DSM, which is not so new anymore, the DSM-5, brought all those together and just created one autism spectrum because it was recognized that those individual diagnoses didn't really mean a lot. There wasn't as much like specificity with those specific terms. So we now have autism spectrum disorder. But as you can imagine, under that spectrum fall the kinds of kids that I often take care of in clinic who have profound intellectual disability. They're minimally verbal. They have epilepsy. They also have autism. We now call those, profound autism. But you have those children, and then you have individuals who have normal to high IQs. They have jobs. They're living independently. They still have a lot of challenges, but they're functioning in a very different, in a very different space than those individuals who need constant support, and they're all under the same umbrella. So that's what's created, I think, a lot of challenge when we talk about autism, and even when we think about advocacy for individuals with autism.
Yeah, I mean, even just getting back to the autistic and on the spectrum. I mean, I'd love to hear kind of what guidance you have even with language, like even sort of like, what do you feel that patients and families prefer and hear? I mean, because it is true. I mean, I think that there's either a worry about a label or there is the embracing of a label. Depending on what that label then gets you, right, or doesn't get you. So I mean, we just want to make sure that we're really sensitive. What do you use clinically? What do you kind of sense that patients and families prefer in that description? Yeah,
that's a great question. And that discussion has been evolving in the autism community for years. I will say bottom line is, as long as we use language that's respectful of the needs of the child or family, I'm supportive of it. I think that the self-advocacy movement in autism has really advocated for sort of diagnosis first nomenclature, which is to say like autistic individuals. So they'll say, as opposed to an individual with autism. I struggle a little bit with that language clinically. I would say I have a child who has autism, has an autism diagnosis. And so I still tend to use that terminology.
Yeah. No, I think that's so interesting because I think we hear a lot about language, especially on the show, and how things are framed and, and just whether it's clarity. Of course, we want to get away from any labels that, just sort of, unintentionally cause, shame or confusion. But this makes complete sense. And what I'm hearing you say, it's like, it's for clarity, it's for access, it's for rigorous clinical care. It's not a definition of a child. We do get asked this a lot. Do we even know what causes autism?
Yes, great question. And in fact, we do, much more than we did 15 years ago.
Already.
So stated simply, autism is largely genetic. Now, that does not mean that every child or adult has like a single gene that we can identify on whole exome or whole genome sequencing. What we know now is that about 20% of individuals with autism have a genetic cause that is identifiable through genetic testing. So it's a single gene or what we call copy number variant. So a change in a chromosome that includes lots of different genes, whether it's a duplication, so too much of it, or a deletion, a missing piece. So that's about 20%. And those are identifiable with testing. Now, those individuals, usually that change is new, a de novo change in the child, not passed down from a parent. And so as you can imagine, in those cases, those are individuals who are more severely affected, right? Because if it's passed down, if that parent had that level of symptomatology, they're probably not necessarily even having children, right? And so these changes that we find in about 20% of kids are really causing significant symptoms. So the testing is really high yield in those kids or adults that have epilepsy, have intellectual disability, have more severe impairment. So then the question is, what about the rest of the 80%? And in those cases, it's still genetic, but we know that it's really more what we think of as polygenic risk or polygenic causes. So that means we all inherit a bunch of common changes, right? The common variants in our DNA. You have a bunch, I have a bunch. And it turns out that there are individuals, if they just inherit a certain mix of those common variants, they happen to lead to a change in the way the brain is wired and can lead to autism. those individuals with the common variants, they tend to be also ones that have more mild symptoms. So on the spectrum might be, again, on the milder end of those that are affected.
Okay, super helpful. By the way, I'm still just really grateful for what you're talking about with the language, because it just reminds me that it's just giving that there's this shared language. You're giving me that shared language, and I'm imagining for the caregivers, parents, community, and teachers, this just makes a really big difference. So I guess in terms of then how these genes are expressed, so I'm going to just call this early signs, you know, and behaviors. Can we talk about that? I mean, what are some of the developmental differences that families might notice early on, I guess, in their child? Yeah,
and a lot of what we know in this space is based on pretty incredible studies that, our group has also been a part of and has led that study and follow babies who might be at higher likelihood for developing autism from birth. So you might ask, well, who are those babies, right? So the most common group are babies who have older siblings with autism. Because in those, think about not those new mutations, but in the other 80% who have these like common variants, they're inherited from parents, right? So in those cases, what we find is that there is a higher likelihood if you have one child already with autism in the sibling. It's about a 20% increased risk. So it's not 100%, but it's about 20%. So that's a really ideal high likelihood group to follow prospectively. And so there was a large international consortium, which I had the privilege of actually leading about 5 years ago, called the Baby Siblings Research Consortium, BSRC.
Yes.
And all these groups around the world basically follow baby sibs from birth. And so we can follow their behavior, we can look at brain imaging, use eye tracking to look at social attention, all kinds of different tools to ask, are there signs before a child actually gets diagnosed with autism? Because we're usually making diagnoses in the second and third year of life.
I was just going to ask, like, when do you start monitoring these siblings? Like at birth?
We can, yes. So some of our studies, so we had studies actually when I was here at UCLA last time that we would follow babies starting at 3 months of age. The other big group that we follow that we've done, my group has done quite a bit of work in, is in kids with genetic diagnoses that we know confer a higher likelihood for autism. So we've done studies in babies with tuberous sclerosis complex, for instance, starting at birth, and can follow them prospectively. So before I answer your question, what I'll say is I just want to be clear, when we do these prospective studies, if we see red flags, we're immediately giving the family feedback. And I think that because of the feedback we give, we're seeing pretty good developmental outcomes in a lot of these babies that maybe if we weren't following as closely, we wouldn't be seeing.
Well, it seems like if you know that there's early signs and you're seeing them, then there's early interventions, which I'm sure that you'll get into, which can make, material differences.
Exactly. But anyway, based on those studies, what we have found is that we can identify changes in brain development using tools like mostly electroencephalography or EEG, which is a great tool to look at how the brain's wired. We have published that there are differences in the brain as early as 3 to 6 months. Now, I want to be clear, those differences, when we do these analyses, we're doing these analyses at a group level. So what we do is we follow babies, and then at the end we ask, how did the kids who developed autism differ from those who didn't? So we're literally running analyses that are looking at differences at a group level. So these findings have not translated yet into clinical practice in that every baby should get an EEG to determine if they're at risk for autism. But we do see differences in brain development very early, which I think is important. An important message to tell folks so that we don't continue to believe that autism just starts magically at 18 months or age 2. Like there's processes underway. So from a brain standpoint, we see differences that early. Behaviorally, by 9 to 12 months, there's been robust, same kinds of studies, robust studies that have shown that there are differences in nonverbal communication. So eye contact, gesturing, social referencing, attention to social features in the environment, attention to faces. Those are differences that we absolutely do see at 9 and 12 months, and those can be identified behaviorally. And so that's led to some changes in practice, in fact. We are now recommending, as you know, to pediatricians that we should be screening for autism as early as 12 months. And there are really nice tools like the MCHAT, the Modified Checklist for Autism in Toddlers, that can be used as early as 15 months, 18 months. And it asks questions about these kinds of social communication skills.
Yeah, when I go to take my kids to the pediatrician, there's a questionnaire and a lot of these questions are being asked.
And those are really, are those perfectly predictive? Absolutely not. Do they cast a very wide net where there are kids that might screen positive that don't don't develop autism,
Right.
absolutely. But what I think it's the way the needle has moved is that we are aware
Right.
that signs of autism start as early as the first year of life,
Yeah.
and we should be asking. And so when I get asked about this, my number one take home, I wish I could say that we're at a point where our biomarkers will be used clinically. It might be that will be the case. I truthfully don't think we're going to be using imaging tools to diagnose in the first year of life. I think they might help us, what I think of as like risk stratify better. So if there's red flags for other reasons, maybe we use these imaging tools to say, gosh, your baby is at a 50% likelihood.
Right.
So let's get this child into intervention, even if it's preventative, right? So that we can just help optimize their development.
So it does make me want to ask that. I mean, are we going to get to a point where parents are going to say, like when in a prenatal place, right?
Yes.
Where people are going to say, oh, can I get genetically screened?
Yes. Good question. So that's already happening at some level, and I have mixed feelings about it.
I do too.
I think that there are some genetic causes, like in that 20% group that I described, that are very highly penetrant for, I'm going to say, neurodevelopmental disorders, not specific to autism.
And just for our audience, highly penetrant meaning?
So that a very high percentage of these infants will go on to have developmental delays of some sort, right? So highly penetrant meaning 90% of these kids are going to have
They're going to manifest them.
In some way. It may not be autism, but it might be developmental delay. It might be intellectual disability, meaning cognitive challenges. It might be epilepsy or seizures. And so those genetic conditions it's valuable to detect those in utero, because we can then start following that child, that infant from birth. And a good example of that is tuberous sclerosis complex, which is a genetic syndrome that we've studied for a long time. Now, TSC, or tuberous sclerosis complex, has manifestations that actually turn up in a prenatal ultrasound. So these babies get diagnosed even before genetic testing is done. And we do follow them from birth because we know these babies are at high risk for seizures, for instance, very early. And we should be, and there's been clinical trials now on prevention of seizures and things like that. So that's a clear-cut example where the testing could be very helpful. Where it gets tricky is if we start conducting genetic screening and find changes where we don't know what that change
like
might
how it's going to
mean.
manifest, or what we say scientifically express itself.
How it's going to,
and to what degree.
Exactly. Where maybe we know 30% of those kids have an autism diagnosis, right? But many may not. That creates, I can imagine, tremendous concern, anxiety, and uncertainty for the family, and for the clinician taking care of them. So I think that's an individual decision, but we are not at a place now where we're recommending that kind of genetic newborn screening or prenatal screening. There, again, certain conditions, Angelman syndrome, some copy number variant syndromes, tuberous sclerosis, like there's certain genetic syndromes where there is a push towards newborn screening that I think is justified.
And there's like a pathway for sort of intervention and support, which there's
and
for this
I will
too.
say that for the newborn screening discussion, really the requirement that one has to do newborn screening is there an actual intervention that you can offer if you test positive? Is
this result actionable?
And I think the piece that, and we just published a paper on an early intervention trial that we did in tuberous sclerosis complex, and we actually found in the trial, it was a behavioral intervention trial in babies, because we were finding early signs in these babies, and the question became, well, great, you're finding early signs, now what? So we said, let's ask if behavioral intervention improves development. And interestingly, what we found in that trial was that both groups, meaning the group that received intervention right away, and you have to have a comparison group in a clinical trial. So from an ethical standpoint, you can't just not give intervention. So we had a wait list group. So they received intervention, but after 6 months. And so the main analysis was done comparing the groups, the group before they got the treatment. So the wait list. Who are waiting, and then those. And we found in our outcome, and I can talk about this now because it's published, is that both groups as a whole made gains in development. And what that led me to conclude, and this is a phenomenon it's not a new concept, but I think it's really powerful, is that there's a surveillance effect, meaning that there's therapeutic value in following the development of an infant.
You mean like just being watched?
And yes, being watched and giving the family feedback about their child's development. Because what our families are doing is they're getting feedback that their child may have some red flags.
Right.
And they're going out and getting better interventions.
And they're paying attention.
And they're paying attention. So we need to understand that better. But I bring that up because I do think, okay, we may not have gene therapies for all these conditions. But if we know that a child has some elevated likelihood of having a developmental disability or a delay or autism, there's value in them being aware of it so that we can support them in acquiring other interventions, following their child's development. Like that in itself might be therapeutic enough.
Yeah, I mean, it sounds like multifactorial too. Like, I mean,
exactly
value. If a parent, you mentioned, some of these questionnaires that we give to parents, or just some of the behaviors that are those early behaviors that are noticed. If a parent feels like something is different, sometimes it's just like an instinct or a caregiver. What would you recommend practically, that they kind of do like this week? You know what I mean? Like they're like, okay, I'm noticing. I'm noticing a lack of eye contact.
Great question. And I will tell every parent, be tenacious if you know your child best. So if you are worried about your infant or toddler, absolutely keep pushing for someone else to pay attention to that as well. Ideally, it should be your pediatrician. But I've unfortunately heard stories of parents who said, I was worried about my child at 6 months, 9 months, and no one would listen, right? So then step 2, if no one listens, is if your infant or toddler is under the age of 3, so if you have an infant or a toddler, you can contact your regional center and access early intervention on your own. You do not need a referral for early intervention. This was something that I did not know as a practitioner until I started working with our amazing folks at UCLA when I first moved here in 2010, who worked in early intervention. They said, a parent can refer their child to early intervention. And what happens then is you call your regional center.
Well, wait, what is a regional center? I think a lot of our listeners don't know.
So it's a state-funded, incredible program that's actually, covered under the Individuals with Disabilities and Education Act, IDEA, which is a federal law that requires our country to take care of children with developmental disabilities. So IDEA, the first part of IDEA is that until 3, your local providers will help you receive whatever services you need. After 3, it actually, most of it gets taken over by the school system. But until 3, it's whatever your local system is. So in California, we call them regional centers.
Yes.
They're state-funded programs, state and federal, that are based on region. And so if you go to, you can literally Google like California,
What's my regional center?
Centers.
Yes.
What's my regional centers? Here's my, we're working on an app right now that's going to
I
help
appreciate
parents
you
with
breaking
this.
this down
because
I think a lot of people don't know what like regional center means.
I know, I agree.
So this is great.
I mean, and I think some of us as providers, and I'm saying that I'm taking
I will
this
tell you
myself, like I'm not saying others,
as
but
a
I did
primary
not
care
know.
clinician for adults, someone said the word regional center to me, and I was like, do I Google that?
Yes. So I will tell you, we are working in our neurodevelopmental disabilities group. We are working on an app. It's almost done.
Great.
That's going to help families with this. It's almost done, and where the family types in their zip code and they're given info about their regional center and services because this doesn't exist. But for now, if a provider or a parent or caregiver types into Google, this is my zip code, what is my regional center, you will receive that information. The regional center will then talk to the parent. They'll evaluate the child.
Good.
And if the child has any delays or concerns, they will start interventions.
I see.
And then at around 2.5, what we recommend, meaning age 2.5, we recommend that the parent then contact their school district. And again, that's also something parents often don't realize, that my child can be in public school at 3.
Yes.
They don't know this. And the public schools are for the most part, especially where we live in Southern California, quite strong in special education. So 2.5, you contact your school, you say, I would like to have my child evaluated for a possible IEP, which is an individualized education plan.
Yes.
They will evaluate your child, and they'll come up with a plan that will support your child's development. And so as early as 3, kids can be in preschool. It's
and
not all day every day.
That's a lot of support.
It's a lot of support. And I will say, and there may be some of my patients and parents might disagree, but I will say at 3, I think public school is better than private for a child with special needs.
I agree. So backing up into, you know, and I love what you're saying too, which is to the parent, which is, of course, you know your child best,
Yeah, you know
parent,
your child
caregivers,
best.
friends, family. Yes, advocate for yourself. Be tenacious. I mean, I think that goes for a lot of diagnoses, but I have to acknowledge, like, it's really hard when
It's
you're
hard, I
a
know.
parent, right? I mean, you're trying to, like, you're exhausted, you're trying to care for your kid, you're trying to figure out if something's wrong, you're, like, worried. But I love this. Start with your pediatrician. Make sure that they're listening to you. If not, obviously, or in addition, there are these regional centers. If a family does come in then for an autism evaluation, just big picture, what should they expect?
So it depends a little bit on what the needs of the evaluation are, like what the parents' needs are really. And I say this because you do not always need a 5-person large team 3-day evaluation to make an autism diagnosis. I mentioned way back in our conversation the DSM.
Yes.
There are very clear criteria for what constitutes an autism diagnosis, and an astute experienced clinician, including a pediatrician, can make an autism diagnosis.
Okay.
And I only say this because I think sometimes parents wait for sometimes years to receive a quote formal autism diagnosis through these teams, and unfortunately the consequence of that is delayed interventions.
All of it,
so
delays interventions, support, understanding.
Exactly.
Right?
So I encourage a caregiver to at least ask a pediatrician if they're comfortable making even if it's a preliminary diagnosis, and if it's not the pediatrician, other pediatric providers, physicians, such as child neurologists with the neurodevelopmental disabilities expertise, and we have a really strong group at UCLA, but there are there's neurodevelopmental child neurologists all over the country now because we have specialized training in those areas. Child psychiatry, developmental behavioral pediatrics. So there are pediatric providers that can make a diagnosis.
Okay, good.
Now, if that's not the right path because the practitioner feels as though, or the parent feels as though they would like more standardized, rigorous testing, and there are a bunch of different standardized tests for not just autism, but for overall development, adaptive skills, co-occurring conditions, things like that. Then there are clinics that can conduct that kind of testing. Usually it's run by a clinical psychologist or someone who's trained in the actual assessments. Those assessments, what I'll emphasize with those assessments is you can get those assessments covered by insurance, although it can be challenging.
Yeah.
And so I find that parents often are paying out of pocket thousands of dollars for those. And
Which
that's why I would say
which is
just
such
take a
a
step
barrier
back
to
and
access. Yeah, exactly.
Huge. But if you are going to pursue an assessment like that, what I emphasize is make sure that assessment does a few things. One, make sure they're assessing for more than just autism, because we need to take the autism in the context of the rest of the child's developmental profile. So they should be testing overall developmental skills. They should be looking at, again, adaptive skills, meaning how does a child live in the world, co-occurring conditions, things like sleep issues, anxiety, mood issues, all GI or gastrointestinal issues, like all that should be evaluated. So, and then thirdly, or I don't know if that was second or third, is that they should be gathering data not just from others, meaning others who are observing the child, like school or daycare, and parents, but also directly assessing the child. So it has to have all those pieces. I've heard unfortunate stories of parents who say, oh, we had a full assessment, and then I find out it was just done over Zoom, and it was basically interviewing the parents, and that was it. So there was no direct assessment of the child. Or it was only testing of the child in one day, and the kid had a bad day.
Right.
They were scared. They had to go into a clinic. They didn't get any data from those who are experiencing the child in other settings. And so you have to have a holistic view if you're going to do an assessment like that. But I would say, as someone who has diagnosed thousands of kids with different neurodevelopmental disorders over the years, and again, this may be a controversial statement, but I would say that probably 10 to 15% of the children that I have seen in clinic have I referred for a more comprehensive team-based evaluation because there were too many complexities and nuances, and usually, almost always, those were older kids or adults. In the little ones, the ones that we just need to get into intervention, we should be able to make a diagnosis
for the majority.
enough to get them in.
Yes. Okay.
Yes. And when I say little ones, I mean like 3 and under.
Yeah.
But even
no,
5
but that's
and
really
under.
helpful. You're saying, like, for the most part,
Yeah.
you don't need this, huge team, huge sub specialist.
Right.
But the advocacy, like, my take homes are from listening to you is like the advocacy, be tenacious, but absolutely the pediatrician. Start with pediatrician.
Start with the pediatrician.
Okay, that's so great. I think when people too, and you've been talking about this a little bit too, which is when people hear spectrum, right? I think a lot of people imagine this like straight line.
Yeah.
But what does spectrum really actually mean?
So spectrum, and it's been used more and more now with the, again, new, quote unquote new, it's been 10 years, DSM, because autism is now officially a spectrum, autism spectrum disorder, ASD. The reason the term spectrum is used is that literally those core features that define it, repetitive behaviors, restricted interests, sensory issues, and social communication challenges, those fall under there's a large range of areas of challenge, level of support needed, co-occurring conditions, presentation, all of that. There's so much variability that it's a big spectrum. And there's, Lorna Wing, who is a very famous autism clinical researcher from, years and years ago, decades ago, had this very famous quote that many of us use still to this day, which is, if you've met one child with autism, you've met one child with autism. Right. And the idea is there's heterogeneity. And she said that before we talked about ASD, right? But I think that the real kind of spirit of spectrum is there's a lot of heterogeneity or there's a range. And I think it's important to embrace that because kids can move on the spectrum even within their lifespan, right? Kids can make lots of gains. Right. They can have new challenges as they get older. So for instance, we see often in especially girls with autism as they approach adolescence, we see an emergence of a lot of co-occurring mood disturbances or anxiety and sleep issues, right? And we have to be aware of those. Epilepsy or seizure disorders often crop up in teenage years in both boys and girls with autism. So, the spectrum can change, right? We see kids who have really high support needs early on in development, and with aggressive interventions and AAC or augmentative communication devices and treating co-occurring conditions, they make a lot of progress and they don't need as much support when they get older. So, even within a child, there can be a spectrum of needs and conditions.
Yeah, I mean, this just seems to matter so much because I do think that there's sometimes an assumption that there's a spectrum, but that you're either on this end of the spectrum or this end. You're highly verbal, and otherwise you're not verbal at all. So I think in the medical complexities and the fact that it can change without time, I think again just lends itself to the truth that these are human beings and they're going to have their own spectrums within their own lifetimes too.
Exactly.
But how that then informs different supports, right?
Exactly.
And interventions over time.
Yes.
Also just seems so important.
And I'll say that I do, and it's sometimes a hard conversation to have, but I try to frame it in a really constructive way, which is when I give a diagnosis of autism to a child and their family, and oftentimes it's very early in development, I am very clear that autism is a lifelong condition. This does not mean that the challenges and impairments that a child might have when I'm first diagnosing them will be the same or as significant. But I want everyone to be on the same page about that from the beginning, because I want us to be ready to be consistently thinking about what kind of support does the child need moving forward. Because I think the greatest disservice we can do for our children is give them a ton of supports early on, support, with interventions and school and this and that, and they make tons of progress. And then we say, at whatever age, we'll just say, when school is ending, when they're 22, say if they're in special ed, or maybe earlier, maybe 17, 18 years old, we say, you know what, they're cured. They're fixed. There's no more autism. We don't need to give this child supports anymore. Well, guess what happens? The wheels fall off,
of course,
right? Because not to say that it's like a disaster, but, a large part of the reason that child was thriving was that we provided supports, and that's not a sign of weakness. It's just a need, right?
No, it's so lifelong.
And so we have to continue to at least be aware and to be monitoring it. And I do give the analogy, and again, it's not always the most popular, but I think it's important, and this is wearing my medical hat, which is if I have a child who has diabetes, right, and we treat them with whether it's something as simple as insulin, we don't at some point say your blood sugars are perfect. You know what? Go ahead and go back and eat those red vines, right? We say we need to keep supporting you.
Right.
And whether that's now largely healthy diet and just monitoring is great, but we're not going to just, sort of
I use the same
close
analogy.
the door
Your blood
on
pressure is
this.
controlled because of the insulin.
Exactly.
Right.
Exactly.
No, I couldn't agree. And I mean, it also just seems like it matters a lot because we can be very realistic, I think, like you're saying, and strength-based at the same time. And you mentioned, what are some of the strengths that you see, I guess, again and again? And again, I know it's hard to generalize,
Right.
About, kids, but I do think that I would love to sort of expand this sort of, kind of cliched sort of
Yes.
image of a kid with ASD. So I would love to know, like educate us a little bit too about just like what does that spectrum look like as well?
Well, I can say easily that every child that I have ever interacted with autism, whether they have no language and have seizures and have very low IQs, or if they're in regular school and thriving but have social challenges, every single one of them has significant strengths that we really need to be able to leverage.
Yes.
I think that, so I'll give some, and I can think of a million patients, but what I will say is that some big buckets. So one is, I think that having social challenges does not mean that you're not socially motivated. Mm-hmm. And I see a lot of kids who really struggle with what we call social cognition. Like they don't know quite how to make friends. They don't know how to have conversations in a way that are, natural and have reciprocity like we're having right now, right? Mm-hmm. But they want to. Mm. And it's hard, and they try. And I think it's a really beautiful thing that they continue to be brave and try. Yeah. And I think that there's a lot of programs out there like Peers, which was developed at UCLA and others, where we can teach kids how to do that. But imagine a world where those basic interactions are hard. Yeah. Like we take it for granted that we can interact with people and have some kind of, again, reciprocity in our dialogue, mm-hmm. right? And read cues from faces. I honestly can't imagine a world where I don't have those basic skills. And so I have compassion for them, and I think they're brave, mm-hmm. That they can live in this world and and just be in school and do sports and do all those things. And so I think that's a huge strength that they just show up every day, right? And I think it's really, really important.
So amazing.
I would say that, I see a lot of kids who, again, are working through some of those areas of challenge, but they have incredible cognitive strength in, again, kind of the more, and again, this is somewhat of a stereotype, but it's true, which is a lot of strength in kind of the visuospatial areas, mm-hmm. Excellent at math, excellent at figuring out puzzles. And those kids and then adults can be absolutely outstanding in certain fields, right? I mean, there was a whole study that looked at MIT professors and their, children and found that there were more autistic traits in mm-hmm. many of those because guess what? They're great at coding. They're great engineers. And those are people who have helped us solve some of the world's big problems and are continuing to do so. Yeah. And so a lot of strengths in that area, right? But I do also want to highlight, again, a lot of the patients I take care of are kids with these genetic mm-hmm. autisms, and they have really, really profound areas of impairment. Mm-hmm. And it sometimes is hard for even their families to sort of think about where are the areas of true strength that we can mm-hmm. leverage. And I will tell you, the place that I often see it, and I give parents a lot of credit for this, is they still see the world and they feel, mm-hmm. And I actually think they sort of feel even more deeply because they don't understand the world the way we might. Mm-hmm. And so it's just raw feeling mm-hmm. and it's raw love, for instance, mm-hmm. towards their family members, towards a therapist who might be the one that connects with them the best, mm-hmm. right? And that level of connectedness and love that they show it's a beautiful thing that I don't think we, not to get on a soapbox about this, but I don't think in our society we tend to really show in the way that we need to because mm-hmm. we're so wrapped up in achievement and how we look to others.
That's
and
right. Whatever neurotypical means, it's very
there's so many
over-constructed self.
Exactly. And these kids have this it's just this beautiful, deep and real mm-hmm. connection to people and a love. And I feel it when they walk into my office. I have patients that I've been taking care of for literally their whole life. and I walk into a room and they like give me a real hug because they recognize me and they know that I've been there for them, in some way. And it makes it all worth it. Like I have parents sending me pictures of their kids graduating from, high school, not with like a traditional diploma, but with their certificate that shows that they can, go out in the world and try to get they'll get some kind of job or whatever it might be. And there's joy in that moment. Yeah. And I get to share that with them because,
they're so lucky to have you though. But there's so many ways to lead a beautiful life.
Exactly. And I will lastly say, and this is what I'm going to write my book on one day, which is because there is nothing that makes me like sicker than when there's disrespect towards these kids and then adults who have profound intellectual disability and, autism and other diagnoses. The R word used to get used all the time, and it still gets used, and I find it utterly offensive. And the reason I find it so offensive, not just because they have value in their own right, is that I really believe that these kids and then adults bring so much beauty to the world because I have seen what they do to the people around them. They not only bring force people to be patient, to be compassionate, but they drive people to do good. Think about how many of our parents, even in our UCLA community, who have resources, they have connections, and then they have a child who has profound epilepsy or autism and they go off and they start a nonprofit to find ways to employ these kids when they become adults. They start podcasts that introduce, opportunities to help, to the world. I have a very good now friend whose child, who's now an adult, has a genetic syndrome, and he started this online, basically a health platform called The Mighty. And it's incredible. And it's basically an online, it was a website, it's an app where people can share stories about their own health issues. And they have a huge, piece of it is around neurodevelopmental disorders. But they share stories that are like stories of beauty and power and and it's just, they get millions of visitors a day to this, platform. And it's called The Mighty because it's really it's positivity. It's positive messaging about, about issues that could be deemed as only negative, right? And so I think these kids make the world a better place, period. And, I feel blessed that I get to work with them, and learn from these parents who are like intrepid warriors of advocating for their kids.
I love it. Intrepid warriors. That's right. Before we go further, I did want to name something that comes up for a lot of families, which is I think that when families or caregivers are worried about their children and they're searching for answers, they quickly can find themselves surrounded by strong opinions and often sort of, I'm just going to say it, miracle promises. And I do want to kind of say for our listeners, because this happens with other, other chronic conditions and as well, that, I'm sensitive to it as a clinician, just as a primary care doc. But, if you ever feel pulled towards something that sounds like a quick fix, it doesn't make you naive at all, but it does make me always want to ask you the question, what are you worried about, right? Or you're clearly trying to help your child or your family member. So I do want to just spend a little bit of a moment here in this next section, focusing on what's backed by science, what's safe and actually helps, and especially without framing a child or an adult, as a problem that needs to be fixed. And so I don't think it's going to come as news to you that there's a lot of miscommunication about autism. I will just put the persistent myth to rest that large, high-quality research and reviews and major medical organizations have found no causal link between vaccines and autism. So
thank you for saying that.
Moving on, I'd rather just focus on what helps kids and families today. But I do think it's even just what's helpful is how do we guide our families, our friends in just finding good information? How do we just clean up miscommunication?
We entered medicine to help people. Yeah. Our goal is not to sit in an ivory tower and do research and not translate discoveries into treatment. That's the whole goal of my research. It's the goal of, what you're doing by having these important conversations with experts. Our goal is to help people. So if I had ways to help people if I had different ways to help people, I would be providing that, advocating for
You're
it,
researching them, yes.
Exactly. And so I think that's what I tell families is be cautious when someone, shares with you these bold statements around the fact that they have a cure for anything, because we don't have a cure. Now, taking a step back from that, what I will say is that in any neurodevelopmental condition, the challenge is that we're dealing with something that is, as we've talked about, heterogeneous, a big range of symptoms, a range of causes, and it's developmental. So it's evolving just even over development. And so the prospect of having one pill or one treatment that's going to address all those different developmental features, behavioral features over time is just, it's a tall order that I think is distracting from what we really need to be thinking about, which is how do we address the key symptoms at key times in development and then continue to iterate on that.
Yes.
So what we know about autism specifically is that the gold standard treatments are all behavioral. And they're not cures, but they certainly greatly can improve adaptive, meaning daily living skills, behavior, cognition, social skills, language. But that's it's not easy. I wish there was a pill. I mean, behavioral interventions take money, they take time, they take constant revisiting and, again, kind of modification based on the child's needs. But what we recommend is intensive educational and behavioral interventions, both in school and outside of school for children. Now, we also know, and this has been, provided in many practice guidelines by the American Academy of Pediatrics, American Academy of Neurology, Adolescent and Child Psychiatry Organization, which is that in addition to behavioral interventions for core symptoms of autism, which we've talked about, there are excellent medications for co-occurring conditions, meaning the conditions that happen with autism that can actually cause a lot of issues, like co-occurring ADHD or attention deficit disorder. The meds we use for ADHD, like stimulants and alpha agonists, so pills, can be helpful for these kids and can really help with learning and other behaviors. There's great medications for sleep issues, which are insomnia is highly, highly common. It's the number one thing I treat in my patients with autism.
I didn't know that.
And I will tell you treat sleep with medications and or kind of behavioral modifications, you can help so many of the other daytime behaviors.
But what's amazing though, Shafali, is that so I'm so glad that you're sharing this, is that what I'm hearing, again, just from an average listener, is that all this work, that in a way too, it's important to acknowledge how complex it is, right?
Yes.
So going back to, of course, there's no magic bullet and there's no pill and there's not going to be a quick cream, because your your adult, they're way too complex for this. And as you're saying, the condition, the disorders, they're very, very complex. And so they are going to require, myriad, treatments and approaches. But it's really, really encouraging to hear that, yes, the brilliant minds, you included, are doing all of this work, that there's this awareness, that there's this community, and it's just growing.
Yes.
The precision medicine. I mean, I barely understand what you're saying with the gene editing, but that it's happening.
It's amazing.
I want our kids, but I want our kids, and again, I say neurotypical in quotes just because I'm even among quote neurotypical kids, there's so much variability.
I don't love the term either.
I know, I don't love the term, but it just reminds me that there's other ways. I mean, I've heard a little bit about reducing sensory overload, in certain environments. Let's say, you want to be inclusive and you want everyone from your kid's class to come over for the birthday party. Are there certain things, even tactically, environmentally, to make, again, I know it's a spectrum of approach, but are there things just kind of
absolutely
things that we can do for our community?
Yes, and I think you bring one very good point up, which is the fact that our world there's a lot of sensory overload. And we, like you and I, have a brain that allows us to tune out the distractions.
These bright lights,
right?
yes.
There's so much going on in our environment at once, and we're able to just focus on each other, even though there's so much going on, right? Children with autism often cannot do that. And so I think just even acknowledging that is a step in the right direction. So certainly we can create environments that are a little less provide less sensory overload, but we also can just be sympathetic to it, so that if there's a child or child with autism at a birthday party, we give them a little space to go take a break from that, and don't judge that, or don't assume that means that they don't want to be a part of. It just means that it might be a little bit harder to be a part of. At our International Society for Autism Research meeting, because we have many individuals with autism at the meeting now, and they present science or they just come to listen, we have sensory break rooms at the meeting, wherever the meeting, it's somewhere different every year around the world, but they're sensory break rooms. They actually even stopped the applause after talks, and they do what's called flat pause, so people wave their hands to just limit that, that loud noise. So there are modifications that can be made like that, and I think a lot of schools now do have those settings, because we're really pushing more and more towards, or pushing is probably the wrong word, we're encouraging increasingly inclusion, where kids, even if they're minimally verbal and they have a lot of behavioral challenges, to at least provide them with some opportunity to be integrated with our, as we're calling them, neurotypical peers.
Yes.
Because there is benefit on both ends for that kind of inclusion.
Yeah, I just feel like the approach of sensitivity and not making assumptions is just something to be extrapolated also just to everyone. Even as you're talking, I'm like, we just make so many assumptions about, other selves. Speaking of philosophy and other consciousness.
We do. And I think that we, again, there's so much we can learn by just being, a little bit compassionate to, and, I'll be honest, and again, this doesn't sound trite, but I think some of our day-to-day, I'll just say, I'll talk about me, is that there are days where I am finding myself, in a complete pity party about something in my life. And I take a step back and just think about how challenging it might be just to live in the world for some of my patients who I take care of, or my families, or my, the parents of my patients who are spending all day just trying to advocate for their child to get the care they need, or making sure their child is safe in the home.
Right.
Those challenges are real, and they still find a way to be joyful about it and to be, advocates. And so I just, it puts, I think, some of my own, complaints into perspective. And I think that's sometimes important for all of us to remember.
It's a lot about like giving others grace. Just assume that somebody else needs grace.
Exactly.
I do want to ask you this before we get into our asking for a friend section, but because you mentioned, parents and families and just carrying a lot, what do you see mostly when they're coming to you? And again, I know it's not just a distinct point in time, but even over kind of the period, what are they carrying emotionally?
Yes, a lot, and it does evolve. I think right now in our current landscape, just in the last year, and I've been interviewed in various settings about this, and there's been really beautiful articles written in New York Times, the Wall Street Journal, other media platforms, which is right now, because of the massive amount of misinformation about autism and I'm just going to say it, false promises about certain treatments being cures, parents are unsure how to proceed.
And on top of everything.
I am so sympathetic to that, because if I were in their shoes, I would feel the exact same way. Yeah. Because you experts, child neurologists who are telling them that, and I don't mean child neurologists in our community, but I mean outward-facing child neurologists who are saying leucovorin is a cure. And I'm just going to say it, like it is the panacea for your child, yet they're being told by, are many providers who follow evidence-based practices that, we don't actually have evidence on leucovorin. So I'm reluctant to prescribe it. How do you navigate that as a parent, right? So I am so sympathetic to the fact that in the end, parents, I truly believe every parent wants to do what's right by their child. You have kids, I have kids. It's our number one priority in life is to do right by our kids. How do you do right by your child when you're being told 15 different messages?
By people who are all calling themselves experts.
Exactly.
It's very confusing.
Exactly. It is such an emotional and intellectual burden, and I am so sympathetic to that. So what I would say to all of us as providers is really, show some grace to parents when they come to you and ask questions about, because the best thing parents can do is to ask questions and to say, you know what? I did read about the leucovorin thing. Tell me why you're not sure about this. And then it's up to them to make a rational decision about it. And then we should respect their decision. I want to be able to have a respectful conversation with my families. And I tell my families, if you are doing something that I'm deeming as harmful, like hyperbaric oxygen or something where I worry about the safety, and there's studies on really adverse outcomes, I'm going to tell you that.
Yes.
But if I'm not sure it's super unsafe, I just don't think it's evidence-based, just tell me you're doing it so that we can be aware, because there might be interactions with the meds I'm treating you with. And I also want you to feel like I'm a safe person that can give you advice in a respectful way, but not judge you for the choices you've made.
No, exactly. And that's I think such a number one message. Really like, we are not judging, and it's so confusing. So I say the same thing. I'm like, let's Google together. Or if you have a question, Bring it to us and let's have that dialogue.
Yes.
Absolutely. And if it's interesting, I get it. I would want to be interested in that too. And if that, if there's a potential, let's talk about it. But let's definitely talk about it through the lens of, of good science and evidence-based and a lot of dialogue.
Exactly.
I think that's, I never want to turn anyone off. We're not like making fun of,
No.
anything, but there are red flags and we're there to partner with you to dissect sort of what's out there and help find like the best and safe way.
Exactly.
No, that's so helpful, and I wanted a real expert
they're
to
really
say
navigating that, and they don't, and I think it's a challenge when we are not offering necessarily easier or better treatments.
Right.
And I have said this to my scientific community in autism. And, I've gotten there's been some debate about this, but I truly believe that part of the cause of this deluge of misinformation and the loudness of it is that we as a scientific community have not been effective enough in communicating what we do know. Autism Science Foundation, ASF,
Yes.
is an outstanding organization. They have podcasts, they have a website that has up-to-date science, and they disseminate information in a way that I think is palatable for the general, audience.
And we'll put a link in our show notes, just so
it's
you know.
great.
Yes.
And then I will say this app that so my lab, my research group is called KIND, K-I-N-D-D, Kids with Neurogenetic and Developmental Disabilities. The app is called KIND Resource Navigator.
Perfect.
And we have my lab, KIND Lab, has a website, but we will have, we're really trying to, not because I need people directing traffic to me at all. I want to have some platform where families can go that they can just help have a roadmap for, hey, my child's 4, they have an autism diagnosis, what do I do next?
And now what?
Right. And
Exactly.
so I was shocked that does not exist.
Yes.
There are, there's reasons for it. Autism Speaks does have a resource database, but it's not fully up to date. So what we're starting with is just having an LA-focused resource navigator with information, and then hopefully that same logic can be used for other areas. But, our parents, the second part to my answer to your question about what are our parents going through is they are just trying to navigate the space with just, not knowing what the next steps are. I can't tell you the number of patients I would diagnose, or they were already diagnosed and I would see them in clinic at when I was at Children's Hospital LA, who weren't receiving a second of resources. No services. Right? I would see kids 4, 5, 6 years old with autism, minimally verbal, who were in school in special ed. Parents weren't really sure what was happening in the special ed program because there wasn't much communication. No services outside of school because they weren't really clear how to even advocate for those services.
So, like for a parent or patient like that, what would you recommend?
So, I always recommend. I think that we as practitioners need to be able to help parents navigate that. But what I tell the parent is always go back to school and regional center.
Okay, that's great.
And I want to be really clear. You are a lifelong regional center client if you have a child with any neurodevelopmental disorder, autism, ADHD, intellectual disability, global developmental delay. There is this perception in the community, and I think sometimes the regional center promotes this conception, which is you're a client till 3, and then you're no longer a client because you're in the school system, and then you're a client again at 22 when you leave the school system. That is not true. You are regional center. You should be a regional center client your whole life.
Okay.
It's just that your actual services will be given mostly by the school while you're in school. So 3 to 22 if you're in special ed. 3 to 22 is school.
Yes.
For adults and little ones, it's all regional center. But in between, there's still regional center. And then I'll lastly say that many of our insurance providers, including Medi-Cal, do cover some services.
Good.
Now, there's variability. I think we could do a much better job. But, ask your provider if they can help advocate for that, whether it's through writing letters to say it's medical necessity that this child with autism receive intensive behavioral interventions. We should be able to we as providers help to advocate for services.
Great. I love it. Okay, quick asking for a friend.
Yes.
I'm going to ask these the way that parents and caregivers have asked us. Number one, could I have prevented autism?
No.
Great. Will my child ever live independently?
Very possibly, and I think that's a question I get asked a lot. It is because it's a developmental condition, we have to keep asking that question as a child grows older and develops, but I think it's always something that we should be keeping on the table and talking about.
Perfect. Did I miss the window? Like, did I wait too long to get my child evaluated?
Absolutely not. There's no critical window, but we do talk about sensitive periods and sensitive windows. So I still will say earlier the better, and really, really push to get a diagnosis and start interventions as early as possible. But I never want parents or caregivers to think it's too late.
I'm going to not make this to a question because I'm going to paraphrase some of the amazing things that you've said, which is, about supporting, our children and when they're adults without trying to change who they are.
Yes.
And I feel like that's just been like a real theme of what you're saying in terms of supporting communication and there's the accommodation, but also really appreciating who they are as individuals.
Yes.
And I'm just really moved by that. I just couldn't think of anything more important. We talked a little bit, too, about if I'm a friend, family member, teacher, and being supportive. I sort of hear you saying sort of leading with curiosity as opposed to correction, but anything else you would want to add to that?
I think that leading with curiosity, but also leading with acceptance. That there are differences, and those differences can be beautiful and can be celebrated. They may be differences that do create some challenges, and then we can be sympathetic to those. I think it's curiosity, but also engagement and acceptance.
You have said so much, but if listeners remember only a few things from today, what would you really want them to hold on to?
So I would, first and foremost, I think we absolutely need to remember to always have respectful conversations about this space. I think that, unfortunately, autism has become a topic that has become emotional, it's become political, it's become highly socialized. And in the end, at the core of it are millions of children and their families who have needs. And so let's talk about that, and let's like celebrate that, cultivate it, respect it, and recognize that these kids and families have needs. They have challenges, but they also have a lot of beautiful strengths. So I think that's the key. Like, we have to be able to talk about this in a way that's not hurtful, that's not mean, and that, again, we remember what the goal is, right? Which leads to, I think, my second really big point, which is, in the end, I do think that with all the polarization that's happened with autism, that we do have the same common goals. Our goals are to optimize well-being and health for kids and adults with autism and their families. And so let's remember that, right? If we can remember that goal, all the rest of it, I think, can work itself out. And then the last thing I would say is that I think that our scientific community has made advances at a rate that we really haven't in all other conditions. It is, the science, especially the neuroscience in autism, is extraordinary. And it is translating into practice in a way that's, again, really moving the needle in clinical care. And I want us to be excited about that and remember that it's, again, for the right reasons. Yeah.
It is so exciting. I cannot believe how smart you are. Shafali, I can't thank you enough for being here. Your leadership, my goodness, UCLA Health is so glad to have you. We are so lucky. I just can't, though, also just tell you how inspired I am by everything that you're saying and your approach. It's also just reassuring. It, to me, seems sort of like your approach to, children, adults, autism spectrum disorder. It's just, to me, it's like a real worldview about how to be a compassionate physician and person. So I'm just really inspired by you in every way.
Thank you. I feel the exact same way back.
I'm just very grateful how you frame this, this whole conversation, and especially just supporting the development, the quality of life, and then just sprinkled on with this incredible, burgeoning science. But just really, and then treating a child's identity as not something to fix, but something to really, treasure and nourish and grow, especially over time. And again, I also will just say, the systems that you're building, kind of for families, and even the ones that you mentioned that are in our own community, it really just shapes how we're caring for children and their families, at scale. So everything you do, I just couldn't admire more. But thank you for your time, especially today.
Thank you.
I do know how busy you are.
No, it's an honor to be here, and I love what you do is so important, especially, I think, right now, because of again, the sort of challenges we have in talking about.
Yeah, but we like
medicine
science and we like people.
Yeah.
And we like great
Me
people
too.
talking science.
I like science and people too.
Right?
So.
And we will put all the links to all of those communities and resources and apps that you mentioned. And to my audience, I'll just say thanks for listening. Thanks for joining us on Medically Speaking. Stay curious and healthy, and we'll see you next time. Thank you, Shafali.
Thank you.